Hi, I'm Meta Spencer. Today, let's talk about health, especially communicable diseases, shall we? Because I have two people here who know a thing or two about epidemiology, which I don't know much about, but I think it's uh, one of the issues that Project Save the World promises to address. We don't get around to it often enough. Anyway, pandemics are a part of our bailiwick, and today we're going to pay attention to them. I have two gentlemen here, are both physicians. Dr. Ronald St. John is a very eminent man. I'm happy to say he's on the board of directors of our organization, bless his dear heart. He was the program coordinator for infectious disease control programs for the Pan American Organization, which is the North and South regional office of the World Health Organization. And he was also with the Canadian Department of Health, and where he directed the Global Public Health Intelligence Network. There's a whole story there about how the government stupidly cut that down just when it was going to be the most valuable. And he was the first Director General of the Federal Center for Emergency Preparedness and Response, which I don't know enough about. Maybe he'll tell us. Anyway, he's still in retirement. He's still very engaged because he goes off to Geneva quite often to work with the World Health Organization. So, hello, Ron. How are you?
I'm fine. Thank you, Meta. Thank you for that introduction.
Neil. Neil Arya is a family physician in Kitchener, Ontario, and president of Canadian Physicians for Research and Education in Peace. And he's chair of, and I think really the founder of, the Pegasus organization, which is a global health conference that I think is really wonderful. And we are cooperating with Neil sort of on a regular basis now, because he has a large number of people that he's in touch with globally doing global health issues. And that's a little bit more than just the medical. It also includes social issues that are relevant to health globally. And he also teaches somehow in the environment and resource studies at the University of Waterloo. So, hi, Neil. How are you?
Good. Yeah. Thanks, Meta. And nice to meet Ron, which we've just done in the last couple of weeks.
I want to ask Ron to give us some background, because you've been, it's too bad the word bureaucrat is a negative thing, because I think you're a wonderful bureaucrat. You have worked in various agencies of governance and so on in ways that are really important. So, if you don't mind my introducing you as my favorite bureaucrat, and you kind of bring us up to give us an overview of what the institutions that I've mentioned a couple of them without quite knowing what I'm talking about. Tell us about these organizations that are trying to protect us through government.
Thank you, Meta. I guess I am a public health bureaucrat all my career, interested in the control of infectious diseases. But so let me give everybody a little bit of background by talking about something called the International Health Regulations. Now, people may not be aware that there is a framework, a legally binding framework called the International Health Regulations, developed by the World Health Organization, and it's to help countries prevent, detect, and respond to public health threats, especially if they have the potential of becoming international, in other words, spreading from one country to another country. So this is a whole set of regulations or suggestions, well, not suggestions, but regulations for countries to follow. And they have a long history dating back really to the early 1900s, and maybe a little bit before, when people came from around the world to participate in international sanitary conferences, they were called. For example, there was an international sanitary conference way back, I think, around 1905 in Cuba, where they attempted to decide how countries should respond and control yellow fever. Now, they've been revised multiple times. The latest revision was in 2005. And the IHR, as they call it, the International Health Regulations, you've got to understand, is a legal framework, but it's not a legal treaty. So it's kind of in a strange position. It does not have quite the force of a treaty, but it does have the force of an international legal framework or agreement.
Mhm.
Now, the member states of WHO and any other member states ratified the terms of the agreements and agreed to abide by them. Now, I'm not going to go into all the detail in that's in the international health regulations, but I just want to mention that there's a long-standing set of provisions that deal with measures to avoid countries' interference with international travel and trade. So when there's an outbreak of disease in a particular country, there should be no restrictions on people's traveling or dealing or trading with that country unless WHO provides advice to the contrary. Well, okay, that's great. Then along comes COVID-19. And it quickly reaches pandemic levels and it becomes a global emergency. Now, and in spite of advice by the World Health Organization to avoid actions that interfere with international travel, all the countries immediately ignored the IHRs, just threw them out the window. And they imposed many measures that did interrupt travel. Things like, oh, you had to have a COVID test before you could get on an airplane.
Mhm.
If you didn't have a COVID test, you couldn't get on an airplane. Or you had to have airport screening measures, or you had to go into quarantine detection after you arrived in a country. And as you know, during COVID, international travel plummeted.
Mhm.
Now, there is nothing in the international health regulations that says countries should do these things. But in addition, the economically advanced countries moved quickly to acquire large quantities of prevention measures like personal protective equipment, tests, laboratory tests, and vaccines. So the international market was quickly bought out by the wealthy countries, leaving the middle income and lower income countries basically without the measures that would help them control the pandemic.
Mhm.
Um, Maybe I could digress with a quick anecdote at this point. When I was working at the Center for Emergency Preparedness and Response, and there was concern in the early part of this century about biological terrorism, it was decided that we should have some antibodies in our national warehouse, that would be uh, antidotes to infectious agents that might be used in terrorism. And when the CDC put out their list of the agents that would be possible candidates, there was great concern internationally. And I was authorized by the Minister of Health to purchase the necessary antibiotics. And we had a regular supplier. I called that supplier and asked how much of an antibiotic at tetracycline we could buy. And he said, well, I have to limit you because there are 3 or 4 other countries already on the telephone line waiting to buy tetracycline. So you have to give me your quote now, or you're going to go to the end of the queue. The point being that in an international emergency, the international market for the necessary goods and services that we need is automatically overwhelmed.
Mhm.
And that creates problems, as explained during COVID-19.
Mhm.
Okay, back to the situation during COVID-19. Well, as early as 2021, there was a general agreement that something more was needed than just the IHRs. And a proposal was made for a global pandemic treaty, in this case, which would be more legally binding than a framework, a pandemic treaty to improve international collaboration, make it for a faster response to possible outbreaks and pandemics, and issue and deal with the fair distribution of vaccines and health tools, equity across the world. The World Health Assembly, which is the governing body, it's like the board of directors of the World Health Organization, agreed, and they set up a system, a body that would start to draft a world agreement. Excuse me. Well, they've worked at it all the way through 2021, all the way through 2022, all the way through 2023. And in spite of many deadlines, they couldn't meet the deadline. And they had multiple drafts and revisions. And here are some of the major issues that caused a great deal of discussion and, frankly, argument. Number one was equitable access to the tests and the vaccines, the medicines, and the technology that you would need to combat an epidemic. The issue here was intellectual property. If a pharmaceutical company develops a vaccine that's successful, well, they have intellectual property bound up in that product.
Mhm.
The countries, many of the middle income and lower income countries said, well, if you give us the intellectual property or share that intellectual property with us, we have the capacity to build the vaccine in our own country. And we don't have to depend on international shipping. We don't have to depend on delays. We don't have to depend on payments and so forth. So there was a big issue about equitable access. A second thing to try to combat that was that it was proposed that when you have a pandemic product like a vaccine, 20% of the productivity of the production, 20% of the production would be given to WHO during a pandemic. Then WHO would equitably distribute the vaccine or the test or whatever it might be. There were other issues in the agreement like surveillance and early warning systems, information sharing. I won't bother you with that. The debate considered to continue through 2024. And the two main issues, again, were equitable access, and the other one was a debate by the countries as to how binding or non-binding would these measures be. How does national sovereignty fit in with global collaboration?
Mhm.
And so some nations expressed concern there would be too much authority to WHO, while others said there wouldn't be enough. Well, they hammered it on and it worked. I know they worked long hours, and they did come up with a final document. And the document was presented just this month to the World Health Assembly, and 124 nations endorsed the agreement. Yay. Finally. The US, interestingly, did not endorse it because they're not participating in WHO or any of WHO's business. The agreement did include something called the Pathogen Access and Benefit Sharing System, and that endorsed what I mentioned before. 20% of a product's of the production of a product would go to WHO for equitable distribution. But there's still a little but. There's an annex now to this agreement. In 2026, this annex will be debated again, and it's to finalize details on equitable sharing of tests, medicines, and vaccines. So that issue is not totally dead yet. Now,
I'm not getting what this extra thing that good.
so they all agreed that we should have equitable distribution of stuff, but they didn't go into the details about exactly how that would be done.
Mhm.
Okay, so they're going to prepare an annex next year, and that annex will try to finalize the details on how you develop equitable sharing of intellectual property, tests, medicines, vaccines, whatever.
Well, hold on. So they are not going to spell out the details until they've got everybody on board and all the countries have signed that are going to sign. Is that right?
Well, yeah. Now the 124 countries signed the agreement in principle, the broad agreement.
Mm-hmm.
But there's still some details missing.
Yeah.
That's the but.
Sounds like
To
big
deal with the
details.
details,
Very
deal
big
with the details,
details.
they're going to have an annex.
Yeah.
Now, the pandemic agreement does not come into force until at least 60 of the 124 countries actually ratify it.
So this is like a real treaty, but you're not calling
Yes.
it a treaty.
Yes, it's a treaty.
It is a treaty.
It
Okay.
is a treaty. Yes. So, yes, we've made tremendous progress. Yes, there is a massive agreement in a pandemic document, and its measures, but there's still some details. And you know, the devil is in the details.
Yeah.
So there's still a little ways to go. Still a little ways to go before we get to have a full pandemic agreement.
What's the
It
general
will be.
idea? If you've got to explain how you're going to make it equitable, sounds like a big task. What's the general principle that they're going to use? Are they going to dole out? I would imagine, say, if I were doing it, maybe I would dole it out to different countries on the basis of their some formula based on their population and their GNP or something, their wealth, so that the poorer countries would get a reasonable crack at it, and it would be proportional to the size of their population. Is that anything like the first approximation of what they're really going to do?
Yeah, they've got to come up with some criteria.
Mm-hmm.
What do you mean by equitable distribution?
Mm-hmm.
Don't forget, they did agree that 20% of whatever the product is would be set aside for WHO.
Yeah.
And the other 80% would go on the international market. But then WHO would at least have 20% of Moderna's vaccine or Pfizer's vaccine or whatever would have 20% of the production that WHO could distribute in a more equitable basis. And WHO uses a variety of criteria for that purpose. Some like you described.
Now, during COVID, my memory is not memory. I'm not sure about this. Didn't some countries finally say, we're just going to grab this formula or the vaccine and make it quickly, even if we don't have a deal with the companies that have, they're just going to appropriate the know-how, or maybe even the equipment to do it. Did that eventually happen? And it seems to me entirely correct and reasonable to do that. I mean, after the fact, you could go and compensate companies that may have not made as many millions as they would have otherwise. But generally, I think, in an emergency like the COVID pandemic, you'd want to immediately just distribute it as widely and fairly as possible. What really happened?
There were some countries that produced their own vaccine.
Mm-hmm.
But I'm not aware of any countries that pirated technology to produce a vaccine.
Oh.
India had its own variation of the vaccine. There was a vaccine produced in England that was different. I'm trying to remember some of the others.
No, you had Sputnik in Russia.
Yeah, Russia had.
Sinovac. Yeah, so a number of countries did that. And actually, in Britain, the one that was developed early on, that they were actually willing to distribute that more equitably. But in the end, that didn't really have the interest of most of the world, like the Pfizer and Moderna products.
Right. Yeah, but I'm not aware of anybody that pirated.
I would have, if you'd made me in charge of things, I would have taken it immediately and said, here, should have an equal crack at it.
Yeah, and I think that those were discussions that occurred 15 or 20 years ago around HIV medicines, and with India and South Africa really promoting that, and that actually forced companies to to distribute those much cheaper. And Médecins Sans Frontières and other groups ended up really pressuring and shaming companies and governments. And the cost of those antiretrovirals went down significantly, orders of magnitude. So, so I think that that's probably what you were thinking of.
Or maybe that's what I'm thinking of, because, I mean, to me, that's just, to be human. I'm sorry, but this is not a time to make money. Um, yeah.
Yeah.
Unfortunately, it was.
Yeah. I guess the interventions I was going to make, Meta, related partly to these issues of equity, since I've taught global health type things, but at the each end of the scale, I think Ron, in terms of public health recommendations, would sort of be in the middle, branching things. I've seen things more with this and with SARS as a clinician. And then also really thinking more upstream.
I didn't even, in introducing you, I didn't mention that Ron had been the guy in charge of SARS in Canada, and the boss, and here you were trying to treat people with SARS. Did you say you actually were doing clinical work with people who had it?
No, so I did stuff in my clinic, but also hospitalist stuff during that time in Kitchener. So it's just really speaking from that experience and things that were planned and not planned. And talking more about the equity type things now would be useful. And so I think in theory that's all great. Equity among countries and within countries, but when things come out, people don't always act according to those principles, regardless of what's written. And in fact, really in Canada, we were considered to be really our government was praised, and Anita Anand, who's now our Minister of Foreign Affairs, was in charge of procurement, and she actually managed to get more of different types of vaccines than would cover the entire population.
Now, are we talking about SARS or COVID?
No, with COVID.
Okay.
And of course, the two viruses are related. This is SARS-CoV-1, so in that, really, Canadians weren't thinking of equity once that happened, and the same was true for stockpiling things which have been shown to be not so effective afterwards. We had ivermectin and chloroquine and other things that were stockpiled around the world. And then within countries, like within Peru, there was a scandal where they had the ministers and people who were academics who got the vaccine early as soon as it rolled out. It was the Sinovacs, which again was thought later to be not as good. But it does seem like when people have their fears that these principles don't really end up being enacted, and it'd be interesting to hear whether these binding agreements, if they come, whether that will help. But we also have to think about within countries and equitable access to what Ron said in terms of testing, vaccines, and drugs. And once again, sometimes it's not the highest risk populations that are looked after in those ways. And I work with refugees. So I'd be interested in Ron's feelings about approaches to equity with regard to all of those things.
Mm-hmm.
Yeah, it's a difficult area. COVID-19 showed dramatically that national interest trump global interest. We still live on a planet that is divided up into national states. And those states will always look after their own people first, their own interests first. Unfortunately, that's how I feel. Um, on some occasions, no, it's different, and one country will help another country with some resources here and there. But in terms of disease and pandemics, it was clear that the nations all broke with the IHRs, did not follow the IHRs at all, and went and pursued their own interests. Will this agreement help? Who knows? It's an attempt to have some detail and some measures, recommendations, whatever that countries will follow, but who knows? And Neil makes an excellent point about, well, once you get the stuff in the country, you get the drug or the vaccine in the country, equitable distribution of that is another place where things break down, and certain interests get into the queue first.
Well, I would assume that the healthcare workers would get it first because they're going to have to take care of everybody else. And so you need a full staff, right? Was that the general principle, or did they not?
It was one of the principles, and within Canada, because we had a COVID treatment clinic, and I was part of that. I was one of the first who got the first vaccine. So yes, they were a priority population in Canada, and
But
I
that
think
was a year or so before there was any vaccine at all. There wasn't anything of any value, any kind of treatment, really, was there in that early period?
yeah, things were more supportive in the early period, and that's why we saw the horrific scenes out of northern Italy, and then later with the Delta virus that in India and in South Asia in general, that people were hunting for oxygen in different ways. So at different times, there's been an imbalance between how the medical system could handle things and the disease. But yeah, in terms of equity, what I was thinking about was beyond that first part. Because of dealing with refugees, even in terms of where you place testing centers, for that matter, and then affordability of different types of treatment, education regarding that, with populations at risk who may not be as literate, or at least not as health literate, and not in terms of language type things, that some of those things aren't thought about by decision makers, and it isn't even necessarily that they're evil or not concerned. It's just that doesn't come to their minds. They're often the louder voices, often in this, aren't the ones who are highest at risk.
In the 2005-06 pandemic influenza plan, we gave a lot of thought to well, when supplies are limited, who gets priority for the supplies?
Mm-hmm.
And it's logical that some people who are essential for the functioning of society to be first in the queue. Healthcare workers, if they're, for a treatment or an antidote. Then you have security personnel, police, firemen. You want to make sure they stay as healthy as possible.
Mm-hmm.
Then you get to, well, what about our political leaders? Where are they in the queue?
Well, I would think it would have a lot to do with how closely the person would have to work with sick people. Anybody who's an ambulance driver, for example, is for sure going to be exposed, but a politician, probably not. Did they take that into account?
It all depends on what the agent is, what the situation is. Yeah, you can have something that's highly infectious that's already circulating in the population, and firemen are being exposed, politicians are being, everybody in any occupational category might be exposed over a period of time. So it all depends. But in general principles, you want healthcare, you want security. To me, those are the two top things.
So I think that those principles are good principles on which to work, but then the devil's in the details.
Right.
Yeah.
But also, I would think in the question of enforcement, I mean, you say people ignored it. Well, frankly, I wouldn't expect anything to be much different. If you're in a scramble for survival, or you think you're in a scramble for survival, you don't really have the kind of nice manners that your mother brought you up to have, or a Sunday school teacher. So, and then there's this whole notion of sovereignty. My impression was that even before COVID, that a lot of Republican politicians in the U.S. were wanting, didn't like having much to do with the WHO because they saw this, any kind of international cooperation of that kind, as a sort of an infringement on American sovereignty. But and that must have, it probably is relevant right now when I believe the U.S. has not signed this, or is it not even, didn't participate in negotiating this recent agreement or treaty, because Trump wants to have a sovereign world.
I think that part of it is not just not wanting to cooperate internationally, but there is a skepticism about the traditional ways of viewing infectious disease that Kennedy has, and many people influence in positions of influence. And there's parts of that where I have some empathy, to be honest. But yes, there's the part about skepticism about the science, and then skepticism about international institutions and telling the U.S. what to do. But yeah, I'd be interested in Ron's.
No, I want to know more about what your skepticism. If you believe they may be partly right,
at a macro level, different countries took different approaches early on. Before vaccines, you had a Swedish approach, which is widely interpreted as being just let everybody get infected. It wasn't quite like that, but basically they felt that younger, healthy people could congregate in medium-sized types of settings, particularly outdoors when the rest of the world was shutting down. And then you had the opposite things of some of the islands. Japan, and then some of the more prosperous Southeast Asian countries, and then Australia and New Zealand, which basically were trying to prevent even a single case. And so there was a total lockdown. So you had the two approaches there, and the U.S. Robert F. Kennedy Jr. and there were some very good scientists, and John Ioannidis, and who are some of the other ones? Jay Bhattacharya, who is now part of the U.S. administration, signed this thing called the Great Barrington Declaration, and they were basically saying this is already circulating among people, and maybe we don't do anything, even in terms of vaccines and other things, that older, more infirm people are going to die anyway. That was that approach. I don't quite agree entirely with that, but I understand that. So there were just different approaches that that the world took.
If I could just quickly go back to one thing, a thought I had, to address Meta's concern about nationalism and so forth. If there is an argument that goes something like this, that national interests can be served by addressing an outbreak of disease somewhere else
Mhm.
before it gets to me, before it comes to us. And that's an argument for global collaboration. The idea, I mean, let's find the problem as quickly as we can, respond as fast as we can, contain it as much as we can before it gets
Well, I
everywhere.
assume that's true. Why is that not obvious to everybody?
Well, because some people sometimes say, well, but my national interests come first. I don't care about over there.
Well, they're stupid.
Anyway,
I mean,
it's
these viruses don't stop at borders. That's
well,
obvious.
I know, and
Anybody can do
the
that.
irony to me is that the world is not as we thought it was because of international travel such a magnitude that and humans are such great vectors of disease that disease travels so fast these days. 24 hours from anywhere in the world brings you to Canada. So, that's within the incubation period of most agents. So some of these things are moot points, but they still linger.
Well,
Uh,
when you were first talking about how everybody uh, uh, started clamping down on travel, I wasn't sure how to read your tone of voice. It sounded like you were leading up to saying that that was a mistake. What do you believe that they should not have uh, tried to reduce travel in those days, those early
it
days?
doesn't, well, first of all, there was no WHO recommendation to
So,
stop travel. In fact, WHO took
yeah.
the opposite position. Second, it depends a little bit on the agent because you you just cannot, as you point out, you cannot shut down countries for any length of time anymore. There's just too much movement of people and goods and trade and so forth. There's too much movement, so
Mhm.
you can't stop disease at the border.
Yeah.
Yeah, and actually, it'd be good to even go back to the original SARS in 2004, to Ron, and even talk about like it was the doctor who was in the Hotel Metropole, and but what Ron had said was really a lot of people are spreading things before they're symptomatic, and so that makes it more difficult just to shut down travel and shut down the disease spreading. But maybe you could speak from your personal experience.
Yeah, it was a grandmother in the hotel. And they came back from the hotel. Uh, she was exposed there, was incubating the infection, got back to her family, got sick with the respiratory symptoms, did not wish to go to the doctor. The son took care of her. She died at home, but by then had transmitted it to the son. And then
Are
the
we talking
sister,
SARS or
SARS 2003.
yeah, okay. Hmm.
And then the son got sick, went to the emergency room. It wasn't recognized. They didn't ask the question of about where have you traveled, and we were off to the races, so to speak. Yeah, when you're talking about shutting down countries or their border, there was remember 9/11, and the U.S. closed its airspace, and Canada followed suit, and we closed the airspace for 4 days. Well, the outcome of that was 45,000 people stranded in Nova Scotia and Newfoundland, and that's not sustainable. You can't sustain it. So absolute closure of the border is not a possibility anymore in today's world.
But you said that the problem was that the WHO didn't recommend that they curtail travel. And they, well, why didn't they? I mean, do you think they should have?
Because it wouldn't stop it, Meta. It wouldn't stop it.
Well, it did stop it in, I think, wasn't it New Zealand, I think, that they didn't have it for a long time.
But New Zealand, and so there are some rare places in the world that are quite unique where there's not a lot of traffic to them. There's not a lot of travel. There's not a lot of people movement. it's quite isolated, difficult to get to, and so on. And yeah, those places could possibly just shut down. But how long can they sustain it? I don't know.
Yeah.
Australia tried hard, and as Neil points out, it didn't work.
Yeah.
Yeah,
My
I
second,
got, I immediately started staying at home and I wouldn't let anybody in. Nobody came into my apartment except people delivering groceries. And that was just, I'd have them come and put it on the counter and go. And that was like once a week, somebody would deliver. Apart from that, nobody came in my apartment, and they still almost don't because I don't go out. I found out that I loved this. I felt so much freer not having to go out and do all these things that I never really enjoyed anyway. So, but after 3 years, I got it anyway. I think it was the third year that somebody, it must have been the delivery man because nobody else was in. And and I did get sick and had to go to hospital. So yeah, eventually it got me, but by then I'd had the vaccine, so I was in better shape. I would have died, I expect, if I hadn't. Isn't that true? You would have expected me to die, wouldn't you?
I think that we have to look at odds of something happening. It certainly you would have been at higher risk than others, and but in terms of whether a lot of these measures really helped, like for instance, early on, people were bringing their groceries, washing them all down, leaving them in the garage before they brought them in. My wife, who had worked in the COVID clinic also, she felt more at risk going to the grocery store there and being in the aisles of everybody. So not all of what we did was necessarily good. I feel actually one population group that would have been at risk were the young people working in the grocery stores there, and they didn't get the vaccine the way that there were some healthcare workers who were at much lower risk than they were, and they got that. So anyway, there was a lot there where we based things not fully on the science. A large part early on was whether masking itself should be used or not. Within WHO itself, just an interesting anecdote. I was there for a project related to health and peace in Somalia. So I was in Geneva the week of March the 2nd, 2020, and then came back March the 8th, and then things shut down March the 9th. But at that time, at WHO headquarters, all they were doing was wiping down the doorknobs and the tables in the rooms twice a day. No, like there was no masking, no other things, and they felt really, even though things were in northern Italy, that they felt, oh, we're all pretty, we're okay here, and as it turned out, it was actually the bordering areas to Geneva where things were just brewing. And at WHO headquarters, they weren't even aware of that.
The other thing to think about when it comes to shutting things down, during SARS 2003, that was a slightly different SARS virus. It was not quite as infectious as the one we dealt with in COVID-19. And it was confined in Toronto, and it was mostly a hospital-based disease for the most part. But we didn't know how much the virus might have penetrated the general population while we were dealing with it because of the incubation period. So we asked people who had been exposed in certain settings to go into quarantine, stay home, don't go out. And, at any point in time in Toronto, there were for a period of quite a few weeks, about 6 weeks, there were about 7,000 people per day that were actually at home. What we did not anticipate, and the mistake we made, was all the secondary problems that have come about when you tell people not to go out. we would get calls on the telephone that said, I know I'm not supposed to go out, but I've run out of diapers. Can I make a quick run to the store and get diapers? I'll be right back, and I'll go back into quarantine. Well, no, that's not how quarantine is supposed to work. Or I need $20 to pay the grocery man who's delivering the groceries. Can I run to the ATM? There were all these secondary social issues that we did not anticipate at all.
Mhm.
So if you think about it from a point of closing down an entire country, think of all the secondary issues that would arise if you did that. And the 9/11 shutdown of the airspace was just a small taste of the consequences of that kind of action. So actually stopping travel and shutting down a country is, in my opinion, just not feasible anymore on the planet we live.
Okay, how far would you go in the other direction? Because right now we have an outbreak of, or several places there are outbreaks of measles, which I understand is the most infectious disease there is, practically. And I assume that people are keeping their children home or something like that. I don't know what they're doing, but I expect that they probably are. This is limiting things somehow. But I remember when I was a child, people would take their children deliberately to visit other sick kids with measles because you wanted to get it over with. The notion was that measles was, not many people died of it. So, as I recall, parents would arrange to have their children exposed at a time when they thought they were more likely to survive it and cope with it better. Am I remembering wrong? And does anybody still do that?
Yeah. Well, I guess I'll speak more from the clinical side.
Yeah.
I'm working a day a week in Brantford at a community health center, and Brantford and Brant County was one of the major sites within Canada and Ontario for the measles outbreak now. And it related a bit to some of the Mennonite population in particular, but a population that doesn't get vaccinated as much as others. And so the measles case is actually much clearer in terms of how we handle that. Vaccines have been really effective, and in terms of what's called herd immunity to prevent the spread even to the unimmunized. If you have enough people immunized, you're able to largely prevent the spread. So within this setting, getting people immunized quickly and isolating people when there is an outbreak, whether it be in a school or other setting, it's actually that there's very strong evidence for doing that, and public health is taking a lead. In terms of measles being considered more benign when other causes of mortality were higher, mortality and morbidity, it probably was. And probably the generation after you, people had chickenpox parties. And now they don't do that so much. So I think it's our tolerance of risk that has changed. But maybe Ron could also maybe clarify things for the audience in terms of infectivity and then mortality and lethality, and how that affects how things are handled with regard to viruses.
Yeah, there is, to be blunt, children do die from measles. And that's not counting the number of children that end up in the hospital with severe measles. Now, is there a way around that? Well, yes, there is. As you described the old days, Meta, and my old days as well, children, you could go and get the disease and you'd become immune and you'd be protected, but you had to go through the disease. The vaccine provides you that protection without having to go through the disease. So, which is better?
Okay, now when did it was DPT, wasn't it? The measles and and whooping cough, and what was the other, tetanus?
MMR,
What?
measles, mumps, and rubella.
Oh, yeah, okay. DPTs, I remember, I used to be.
That's diphtheria, tetanus.
That was many years ago when I worked for a doctor and I did urinalysis and did the bookkeeping and things like that. And I was the only person, who wasn't a doctor in the office. So, but I remember that everybody would take all the little kids would have the DPT shots. Now, as I understand it, I don't remember when DPT came in, when they had vaccines, but when I was a kid, I know I had measles, I had chickenpox, I had whooping cough. And I think now I see that there's a sort of an upsurge in whooping cough again. And I bet it's because if the kids haven't been taking DPT shots, that's why they get measles, but they probably also get the whooping cough, right? Or some of them anyway. But I remember being really sick with whooping cough, but measles, it itched, but that was it.
Yeah, I think we're dealing with a couple of different things, and probably not worthwhile going into so much. But as Ron says, measles, mumps, rubella, that are viral diseases, but are ones for which our vaccine is a live vaccine. And so the vaccine itself has some risk to the individuals getting that a bit more, but is really quite effective. The reasons for outbreaks of pertussis, and we had something around 25 years ago, a little bit of an outbreak, and now it's that we have that now, but the reasons for that are a little bit different, I think. And
when did it come in? When did the vaccines begin? Because I'm 93, and that's why I got the disease instead of the vaccine. But when did it become available?
So I think that the measles, mumps, rubella, that was around 71, 72, wasn't it, Ron?
I'm trying to remember, it's been a while. Yeah, I think so.
Yeah, and I think the tetanus, diphtheria, polio, pertussis types, that was a bit earlier.
Yeah.
And then we've had different types of more modernization of that with an acellular pertussis type of vaccine. So there have been some ways in which these things have been refined over time. And then we also refine the schedules with which we immunize people. But actually, I'm going to go back to another topic there with the equity issue, because of my teaching on peace through health, early on, some people who were involved with Israeli-Palestinian health initiatives said, "Oh, Israel giving the vaccine to Palestinians was an example of peace through health." Or people looking at that type of vaccine diplomacy, just like the health diplomacy that we've talked about in other settings. The vaccine that Israel gave, it wasn't really quite given. Sometimes it was expired vaccine, and it wasn't the Moderna type of vaccine that people were getting in Israel. And Israel, some would argue, had responsibility as an occupying power to be serving all of the people, so it wasn't even a gift that way. But vaccines may be used as much as a weapon than as an opportunity for peace building. And I just wonder if Ron has any thoughts about that. Like what we had said before was that if people in your region are protected, that protects you. Like say, for instance, if you've got a polio outbreak, that threatens the neighbors, and so there's a reason for international cooperation with that. With vaccines, it may or it may not be the same thing.
Yeah, there are rules. Sorry. The rules propagated by WHO, I think, and International Trade Organization about the distribution of expired medicines and vaccines to other countries so they can use them. That's a no-no. But yeah, there is a concern that sometimes these things could be used for nefarious reasons as weapons.
Explain that.
Just let me add one thing as an example. The U.S. was providing almost all of the medications to treat HIV in Africa. They've withdrawn all that.
Yeah.
So that now there are no drugs in to treat the HIV cases, and people are going to die. I mean, that's unconscionable.
Well, absolutely. And that's through the USAID, right? And
Yes.
I understand that it's also going to lead to a lot of deaths from tuberculosis.
Yes.
Yeah. But how did you, I think Neil said something about vaccines could be used as weapons. I mean,
I wasn't. I was talking about access to vaccines. Not really. I wasn't getting into any bioterrorism types of things there. But yeah, no, it was just more that the point that rather than being a source of cooperation and creating equity, that it would be used in the opposite way of perpetuating inequity.
Okay. Well, we're getting toward the end, and I wonder if there's any message that we want to promote about what, if anybody wants to be an activist in trying to make sure that good policies get advanced. I assume, of course, that Canada will be a signatory to this new treaty.
Yes.
Is there anything else that needs to be done in terms of public awareness to make sure that the best policies are adopted? And I assume you're totally behind this thing that came out of the WHA, right?
Yeah.
Yeah. Well, what do we need to ask people to do? Is there any need for publicity or something of that kind?
I would go more upstream, and of course, we'll have another talk about ecosystem approaches. But I think in terms of thinking about equity and trying to get things to the most at risk populations, sometimes that and like it would be to each according to their need, from each according to their ability. That sort of way of developing effective public policy. So I think that it involves really collective decision making at various levels of government to try to see how to enact those types of policies. So I think Ron's been much more on the front lines of that sort of discussion, and so I'm interested in how he sees being able to promote that at different levels of government.
Well, as an individual, it's I think the best I could think of is to monitor, in this case, our country, Canada's foreign aid policies, and especially paying attention to those that might deal with health issues and how Canada's strengths, academic strengths, research capacities, and so forth can be used to enhance equity issues in the country's foreign aid policies. So I think you do that by keeping in touch with your MPs and following the news media and so forth. And when you have a chance to express an opinion in favor of global equity and collaboration, do so. That's important. Thanks.
Got it. All right. It's a good message. And thank you very much. I hope this turns out to be useful to somebody, but certainly this is a time when we're thinking about these issues even more than usual. So appreciate your contributions, friends, and see you again soon. Okay?
You're welcome.
Bye.